And the first lecture is going to be the lecture that everyone is waiting for. It's the highlight of our conference.
Yes.
So the topic is going to be the keynote speech. Duodenal Switch, what can we learn from history? And I would like to invite our speaker. He is from Hospital Clínico Carlos Madrid, who is also the Professor of Surgery Chief. Please give a warm welcome to Professor Antonio Jose Torres.
Okay, so good morning. Okay, first of all, I'd like to really thank you, Mr. Dean. It's an honor and a pleasure to be here. And also I want to thank, all the guys that allow me to share with you this, especially Torres, where were you? It's the idea of coming, of having me here. But many years ago, Torres tried to, that we can make it, but finally I'm here. So, Mr. Dean, thank you so much. And all my colleagues there, CK and all Dr. Rao, all my friends here. I share with them many issues. And also even the more senior, surgeon there in the hospital that we met yesterday talking about robotic surgery. Thank you so much for allowing me to share with you these couple of days here. It is my first time in Thailand, and I hope I will enjoy, this country. I have to remind me, where this country is located, because we were having the map, in terms of being aware about where we are. And I'd like to thank also Medtronic. We were talking yesterday with the Medtronic guys for their interest, their aim of education. I think it's going to be very important, the partnership between, the university and the hospital and the different companies, especially Medtronic, for its interest in improving the knowledge and the quality of surgery that many surgeons all over the world are performing. And said that, now I'm going to start my task today. My first task is to talk about what can we learn from history. This is my disclosure, but the main disclosure is what do you see here, is what we do in our Department of Surgery in Madrid. You can see here we perform sleeve gastrectomy. We perform also the same percentage of SADIs, CS1 anastomosis, duodenal switch, and Roux-en-Y gastric bypass. We are now performing more and more revisional surgery, now about 15% approximately. You can see here that the only procedure, more popular procedure, we don't do in a day after day basis is one anastomosis gastric bypass, because we consider more physiological to perform. You have to perform one anastomosis. It's more physiological to perform after the pylorus, not in the stomach. But it's going to be a philosophical approach. But anyway, bariatric and metabolic surgery is like the galaxy war. It started many years ago. At the beginning of the last century, some surgeons, they realized that when they operated patients for gastric cancer or duodenal ulcer, they performed gastrectomy. And the reconstruction was Billroth 2, Billroth 3, Billroth 1, and they observed that their diabetic patient improved. They didn't know why. It was the beginning of the last century. Since then, many people here, you can see Mason with the gastric bypass, and then Balthasar, and then in 1998, this guy, Nicolas Copinaro, is a brilliant guy. He launched his biliopancreatic diversion. And this operation was trying to overcome the problem that at the beginning, this operation, the partial ileal bypass, led by these guys still alive. He's 90-something, 94, 95 years old, is Henry Buckball and Dr. Barco. It was the first time in all the USA history that the NIH sponsored a trial in terms of studying how to go down the cholesterol. It was a POSE study in 1963, sponsored and supported by the National Institute for Health in the United States. Since then, no one has been sponsored there. And they demonstrated that doing this GI manipulation, the cholesterol was down, and the cardiovascular event was were much less. But this partial ileal bypass had a lot of problems and malabsorption because there are a lot of problems. Then Nicolas Copinario, in an attempt to overcome these two most important problems, because the operation, the back-valve operation was interrupting, stopping, and damaging the enterohepatic circulation of the bile acid. Do you remember how famous are the bile acids now? Then, Nicolas Copinario was thinking, something is happening with the bile acid recirculation. And then the other is to exclude the very long blind loop. In terms of overcoming these two difficulties, Nicolas Copinario launched his biliopancreatic diversion. But also, the anastomosis that Nicolas Copinario performed was very close to the ileocecal valve, 50 centimeter, 50 centimeter. It was a huge hyperabsorption, let's say, inducing some malabsorption. But he published extraordinary results 20 years, not only regarding the weight reduction, but also regarding the resolution of type 2 diabetes 20 years or more, with a follow-up of 64% of the patient, 20 years, and with this number of resolution of improvement of their diabetes. So the operation worked very well, reducing the weight loss and also controlling the metabolic profile of the patient, but also has some cons. And this is the reason this guy, Douglas Hess and Picard Marceau, Douglas Hess in the US, Picard Marceau in Canada, they launched the concept of duodenal switch. But duodenal switch was a combination of the idea of Nicolas Copinario, idea of this guy. Many of you can recognize him, is Dr. Tom DeMister. Tom DeMister did the duodenal switch for treating untractable ulcer, not thinking about nothing about obesity. The idea of diverting bile was, because there is no helicobacter pylori this time, there is no medication against ulcer, so the ulcer was recurrent and a very serious disease. Combining these two ideas, switching the duodenum and the idea of Nicolas Copinario, these two guys, they launched the concept of duodenal switch in 1988. At the same time, the year later, was Picard Marceau in Canada. In Spain, we had another pioneer, Aniceto Baltasar. You heard something about him. He was the pioneer. They created a duodenal switch club. I used to belong to this club in the US at the beginning, many, many years ago. And then there is no doubt the duodenal switch has been demonstrated as the time goes by, absolutely the champion. Regarding many papers, he had Bookbill, some meta-analysis, Antoine in US, Marceau in Canada, Topard in France, Hess in the US, showing the results regarding the weight loss and controlling the metabolic comorbidity are very, very, very high. This is the class, this is the guy, the Spanish guy, Aniceto Baltasar. This is Douglas Hess and Picard Marceau, younger than now, and now, member of the club. So this procedure was perfectly standardized laparoscopic procedure. At the beginning, Picard Marceau, Douglas Hess, and Aniceto Baltasar, we were performing open surgery. Do you remember? Laparoscopic surgery started early 90s. So, to perform a duodenal switch open was challenging, but not so challenging because it was an open surgery. But to perform laparoscopically was much harder because we didn't have those energy, bipolar, all these staples we have now, the Signia. We didn't have this kind of, now we have a clip and a scissor. Clip, clip, scissor. Clip, clip, scissor. And so, imagine to perform a duodenal switch those times. Me personally, I spent in operating one patient 14 hours, 1-4, one patient, laparoscopically. You can understand why we developed the one anastomosis duodenal switch. Let's continue. Oh, here, a very standardized procedure. They got the sleeve gastrectomy to preserve the antropyloric area, and the common channel was 100, mainly in Picard Marceau and Aniceto Baltasar, but Douglas Hess was changing the common channel depending on the total length of the bowel in those times. This is the principle of the duodenal switch. It's a vertical gastrectomy. And then, to cut the duodenum distally to the pylorus, and then counting from the iliacocecal valve 100, we put it up to the duodenum, and then do the duodenal switch, 100 centimeter from the iliacocecal valve, 100 centimeter and 150 of the alimentary limb. Oh, oh. What happened? Okay, it's gonna be, 150 alimentary limb and 100 common channel, was in total 250. And then, here you can see the different parts of the duodenal switch, a gastrectomy. The biliopancreatic limb is a very long biliopancreatic limb, a common channel 100, and alimentary limb 150. And in this way, we can preserve several properties of the functional physiology of the stomach, in what happened in the common channel, and what happened in the alimentary. Oh my goodness. Oof. It's too fast. I didn't do. Okay. Now, and then, with this strategy, this is the paper published by Douglas Hess. Let me highlight that this procedure were mainly performed open, in an open surgery, no laparoscopy. The result was absolutely 12 years after the operation, 92% of follow-up with a very nice result regarding weight loss and a very excellent and good result regarding the quality of life of the patient. Here you can see this is the Hess paper. This is Picard Marceau experience in Canada. Here you can see regarding all the different data regarding the different treatment or improving or the metabolic parameter and also the weight loss in a very outstanding manner, long term, more than 20 years. So the follow-up we have with the patient with duodenal switch is very long. We have tested this procedure for a long time. Also, regarding the lipidemic profile of the patient was better. When we are talking about the metabolic profile of the patient, we almost think about type 2 diabetes, but we must think also in lipidic profile. That's increasing the cardiovascular risk of our patient. Here you can see, the effect of DPDDS, also very metabolic profile of the component of the metabolic syndrome. And also, more and more papers are coming up showing us the huge improvement in the quality of life of the patient after duodenal switch. This is the paper coming from Michel Gagné and Alphonse Pom in Cornell University regarding the different quality of life study regarding the SF36 and also the quality of life regarding that. So, also, have been demonstrated that compared with the Roux-en-Y gastric bypass, in this paper published in 2012, when we compare the benefit of duodenal switch versus Roux-en-Y gastric bypass in 2012, the results with a similar rate adverse effect. A value alternative going to be much better, controlling type 2 diabetes and hyperlipidemia. And it's a limited surgeon and surgeon with experience. It was so challenging in 2012 that this paper advised, the surgical community to select the different teams for performing duodenal switch because it was very challenging. This is the reason of having a club. The many surgeons, we call them the duodenal switcher guys. Canada, US, France, some center. Very few people all over the world, but very nice result, right? But then, nevertheless, again, the champion is no weight about that. So the duodenal switch demonstrated that it was the best metabolic result of all procedures. I have to highlight not only weight loss, not only controlling or improving type 2 diabetes, but also controlling or improving the dyslipidemic profile of the patient, hypertension and other components. So, however, it never became so popular. Why? Really, it was more complex, especially when we started laparoscopic surgery. It was very demanding to perform a laparoscopic duodenal switch those times, to do the sleeve, to dissect the duodenum, to transect the duodenum, to divide the ileum, to perform the duodenal ileostomy, then the ilioileostomy, then close the mesenteric defect, then close the Petersen defect. Whew. A huge task. And of course, even we are performed the anastomosis very close to the ileocecal valve, 100. So it has some problem regarding hyperabsorption. So is it the best operation? What complications would we expect? Those complications happened. Malodorous stools, untractable GERD, sleep dilation, malnutrition 4%, micronutrient problem, and deficit in fat soluble vitamin. It happened. So this is our duodenal switch. We were member of this club. Open surgery, we were starting open Scopinaro procedure, then we shift to open duodenal switch with this 14 hours for patient. And then it was our duodenal switch in 2000 and 2007. A total alimentary length of 200 plus 250. 250, following the principle of Scopinaro, trying to merge with the principle of duodenal switch. So, then those years, this guy, Robert Rutledge, they launched the concept of procedure with one anastomosis. So we saw that, we were thinking, okay, it's going to be one anastomosis gastric bypass, why not to do one anastomosis with duodenal switch? This is the reason of the basis of studies. Coming from the Scopinaro procedure, Scopinaro, Roux-en-Y duodenal switch, and SADIS procedure, acquiring the approach of one anastomosis gastric bypass. It would be more physiological to perform this anastomosis post-plurically. So we decided to switch the switch to one anastomosis duodenal switch. This was in Madrid, 2007. We start thinking in performing this procedure. So in the end, we tried to do a modified biliopancreatic diversion. Just it was one anastomosis duodenal switch. Now our hypothesis, and this is myself in 2007, was to do one loop duodenal switch with simpler regarding the surgical approach. The complication after the operation would be decreased because just one anastomosis, no closing mesenteric defect, safer, and probably the long-term metabolic and weight loss result will be not very well important, jeopardized. But the problem was, what's going to be the common channel? Okay, we think the common channel is 250, but if we put 250 and our previous common channel was 50, we are multiplying by 5 the length of the common channel. Would it work? No, we didn't know that. So you made the decision to perform 200 from the ileocecal valve in the middle. Not 50, not 250. We decided to start our IRB study under IRB 200 from the ileocecal valve. This is what we do. 2 years later, in 2009, we revised our first 50 patients. What happened? The procedure was safe. We didn't have any leak with this first 50 patients. Was effective. We had a huge excess weight loss, 100%. Too much, but very nice. But the drawback was we have 8% of malnutrition that required revisional surgery. How we think, going to be 16% long term, we changed to do 250, increasing 50 centimeters of our initial length of the common channel. So this is the initial approach, 200 from the ileocecal valve. I want this one anastomosis. And then, the present procedure is this, based in this cartoon, performed by Caetano Marquezini, a surgeon from Brazil. To perform a sleeve gastrectomy over a very wider bougie, 18 millimeter, 54 bougie, to perform one anastomosis after the pleural, preserving, the antropyloric area. At the beginning, the first 50 patients, 200. Then we move to 50. But the most important thing is to perform a sleeve gastrectomy not very narrow. Not to do a huge restriction and some hyperabsorption the same day on the same patient at the, in the same procedure. So going to be not to do a very narrow sleeve. You can use a narrower bougie, but to go a little bit far away when you are performing the stapling of the patient. So you're going to need the final view with us preserving the antropyloric area, the parallels as distally as we can here, and to perform the duodenal ileostomy with the afferent loop and the efferent loop, mainly 250 from the ileocecal valve. This is a cartoon representative what we do, the SADIC procedure. We divide we perform the sleeve under a very wider bougie. Then we dissect the duodenum. You will see during this couple of days all the technique and all the nuances regarding the surgical approach. As far away as we can, our limit is the duodenopancreatic angle, and then we divide that. We count from the ileocecal valve, and we, in this case, this diagram is 3 meter, 2 meter 50, 3 meter, or a proximal, duodenojejunal bypass that Dr. CK will explain to us later on. And this is the way that the food is going to be coming there. So in the end, this duodenal switch, or the one anastomosis duodenal switch, is going to be preserving the antropyloric area. It's going to be important. And we are including being moving up the protagonism of the ileum. The ileal surgery is still very important. So we consider in this way a very physiological surgery, this approach. So again, this is Dr. Roux. Dr. Roux, Carl Roux, is a French guy. They invented the Roux-en-Y in terms of avoiding the alkaline reflux into the stomach after gastrectomy and to decrease the tension in the oral anastomosis in an open area. So when we were looking for investigating why duodenal switch is a Roux-en-Y, we didn't find any answer. There is no answer in the literature. It was the costume. I did that because Picard Marceau did that, because Douglas Head did that. But there's no way, there's no reason, because Roux was for this guy, not thinking about nothing about bariatric surgery. So one anastomosis technique permits a longer common channel than the Roux-en-Y. It's going to be a milder malabsorption, less number of bowel movement, better quality of life, a longer time of contact with the bile acid and mucosa, a greater stimulation of the TGR5 receptor, the greater GLP-1 secretion, and a better metabolic effect. And so SADIS has a very long biliopancreatic limb. We take care of the common channel. We don't care about the biliopancreatic limb. The most important thing for avoiding problem is to know the length of the common channel. And again here, the bile acids are recovering their protagonism at present time. We are increasing the bile acid absorption. We are stimulating the farsenoided X receptor and the TGR. We increase the stimulation of L cell, and of course the incretin effect inducing the secretion of GLP-1, PYY, oxytomodulin, fibroblast growth factor 19, and other factors, beta hemolytic factor, very important. This is a contribution for the Japanese guys. All of you know, I learned, during visiting CK some months ago, how this outstanding work for these guys, showing how it's going to be important the length of the biliopancreatic vein in terms as longer, the body weight is better, and the metabolic profile of the patient is going to be much better as longer is the biliopancreatic limit. It's a very important work and experimental basis performed by our Japanese colleagues. So the greater improvement effect after DGB with longer biliopancreatic limb. And of course, we have some experience in Europe. It is a sub work about our trial, Iberica trial, comparing Roux-en-Y duodenal switch and SADIS procedure, as he's comparing the GLP-1 secretion with the much higher in the SADIS patient compared with the Roux-en-Y gastric bypass. In this profile, not only GLP-1, but also GIP, another hormone going to be higher. The good hormone release after gastric bypass depends on the length of your pancreatic limb. Here you can see how it's going to be important. In SADIS patient, going to be increasing of the GLP-1, GIP, and PYY much better than the standard Roux-en-Y duodenal switch. And now you're going to be This is the conclusion of this work. The group of Portuguese, the subgroup of our patient, including this clinical trial, led by Sofia Pereira and Mario Nora. Here, in summary, patients underwent studies, have a longer bile pancreatic leaf, had an increase of bile acid interaction with the GLP-1 cell, is increasing GLP-1 secretion, and then the increased absorption in this alimentary limb of the glucose is going to be increasing of the insulin production, insulin secretion, going to be very insulinotropic effect. So again, our colleagues from Japan, the group of Miyashi and Uno, going to be important the secretion of the bile pancreatic leaf regarding the absorption of the bile acid. Here you can see a very nice study published by the group showing how we can analyze the enteropathic circulation regarding the length of the bile pancreatic limb. These bile acids are absorbed in this loop and going to be directly increasing many actions. Here you can see a diagram regarding the length of the bile pancreatic. As longer is the bile pancreatic limb, more is the absorption of the bile acid. And in the end, we are going to have the bile acids were reabsorbing the bile pancreatic limb, and in the end, this important role that the bile acid has now regarding the effect, that there are different adipose tissue, the brown adipose tissue, the white adipose tissue, and the way this bile acid, the absorption, acts on this is different. In the brown cell adipose tissue, on the muscle, the liver, intestine, the brain, and the pancreas, doing this all hypermetabolism increases the gluconeogenesis, increasing the insulin secretion, decrease the appetite in the brain, and also increasing the insulin secretion. All these this anti-inflammatory effect of the bile acid is so important now as Nicolas Copinaro thought many years ago. So it's going to be liganded with a very important nuclear receptor, especially farsenoided X receptor, and the G protein coupled bile acid receptor. And here you can see also in this study, was performed by the Portuguese group, showing that even the absorption of the brain-chain amino acid was superior in studies than the BPDDS, the standard Roux-en-Y duodenal switch. Here you can see it very important. And also, this kind of brain-chain amino acid, valine, leucine, and other that, they're going to be this aminogram performed with the spectrometry. Going to be very interesting, showing how these, even the amino acids are absorbed better in the studies that the bile pancreatic DS and the Roux-en-Y duodenal switch is due to the conformation 1 anastomosis not having nothing to do. Again, this production is going to be important, demonstrating a very physiological surgery. And of course, regarding the surgical approach, it's going to be very important, not only to not divide the right gastric artery. We are not focused on doing that because we are preserving not only the blood supply, but also the vagus nerve innervation going this way for the lesser curvature of the antrum, and that is our dissection over there in terms of getting, for course, preserving the gastrointestinal artery, getting as much duodenum as we can, 3/4. Our limit is the pancreato-duodenal angle, as much duodenum as we can. It's going to be very important, to perform this dissection here. Duodenum, the right gastric artery here, the gastrointestinal artery is beating here. This is the plane, our plane here. It's a very democratic dissection. If you don't see nothing abnormal, there is no congenital abnormality. The bile duct is never anterior to the pancreas. We dissect this area. This is our room, our plane. If you go close to the duodenum, you are in no danger at all. So the pylorus prevent massive bile reflux into the stomach. One of the topics this couple of days is bile reflux. We'll talk later on about that. But it's not only preserving the pylorus, it's also important to preserve the antrum. It's going to be important. Preserve the antrum, not only anatomically, but also from the vagus nerve innervation. The antrum preservation warrants the elimination of the physiological gastric reflux, as we have now. We have some bile in our stomach, and this bile is expelled by our antrum. This is working properly, right? So, SADIS is not a novel technique in the end. It's a simplified duodenal switch. Similar basis, easier to perform, less complication, and less secondary effect. It's not a novel technique. It's similar basis. A long BPD, biomagnetic limb, plus mild restriction, plus short and non-common limb. In all these episodic procedures, the most important part to know is the common limb. Again, it's not a novel technique. It's easy to perform, just one anastomosis. After when you finish your dissection, you only have to do one anastomosis. And then, no mesenteric opening. I know, it's mandatory to close the Peterson defect or not. In our department, we don't close. When I operate outside home, I close. But anyway, just in case, not such thing, Dr. Torres, we have a Peterson defect problem. Less post-operative complication. It's a simplified duodenal switch. Avoid the ileoileostomy. It's easier and shorter performing. Again, it's not a novel technique. Less secondary effect long-term. Increase the length of the common channel is very important, and without jeopardizing weight loss, as you will see later on when we present our results. And easy to revise. It's another important advantage. If you want to dismantle, to revise a SADIS, the only thing you have is to put a cartridge here and do whatever you want. Elongate the common channel, perform an anastomosis to the jejunum, do a proximal duodenojejunal bypass. To do a wrong way, gastric bypass, you just cut here. So even in the worst situation, it's very versatile to correct the problems. But there's another important present approach, is to introduce SADIS in the concept of duodenal bipartition. The concept of bipartition is here for staying, especially in South America and in Brazil. And we already are immersed in a very nice study, I'll show you later on this couple of days, is to do a magnetic lateral duodenoliostomy, introducing the magnetic surgery again, recovering from the last years. It's going to be to put a magnet here, and to put right here, and to create an anastomosis by pressure as the time goes by, approximately a couple of weeks. Right here. And what will we do? We are immersed in a clinical trial. We already finished it, and we already published, as you will see there. It's going to be do the laparoscopy. We are counting from the iliacocecal valve. We go 250. We put 2 clips in both sides of the mesentery, and then we put a clamp after trace angle. The endoscopic, put a magnet. We trap the magnet with this magnetic tool, and we move down after removing this clamp for avoiding having gas in the bowel. We move down until our mark 250 with this magnetic device. We go down until we get our clips. Here our clips are here, and then we bring it up this ileum to the duodenum. In the meantime, the endoscopist has put, you can see here, the other magnet here. This is the light. We put together both magnets post-pylorically. We remove this magnet, and then here you can see the anastomosis between the duodenum and the ileum. So the food is, this is the control of the endoscope here. The food can be the normal way and through the ileum. Is the endoscopic approach to the magnet. And then, you can do, include, and then we perform, the sleeve gastrectomy after performing the magnetic. We already complete our sleeve. It's going to be a sutureless and non-bowel opening procedure. It's a lateral duodenal bipartition. We'll see later on, tomorrow probably, I don't know when, or today, later on. We already have experience in completing the SADIS. 1 year later, if the patient regains some weight, has some problem, we can dissect the duodenum distally to this anastomosis, put a stapler, and we already completed studies without opening the bowel. So it's going to be very attractive. Now, in summary, studies and the duodenal switch, modified duodenal switch, makes sense because in a new absorptive procedure, we can delete of our brain the word malabsorption because we are not performing any anastomosis so close to the ileocecal valve. This is a modification of a very test duodenal switch, excuse me, procedure, preserve the gastrectomy, preserve the anterior anatomy, no retained gantry, no need of one way, maybe controversial, no need of closing mesenteric defect. This is the first time I present our 100 patient in New Orleans, 2016. Here you can see our first 100 patient, 5 years follow-up. It was a poster. And then those time, in this meeting, SMBS published a paper in SOAR considering studies investigational in this paper. Then, afterwards, they were endorsed by the IPSO in several occasions, a couple of them. Now we are revising our next endorsement. And then, and then after that, study was considered, even by SMBS, considered 2016 investigational, and now they are endorsed, the SMBS, like a modification of the Roux-en-Y duodenal switch, endorsed by SMBS as appropriate and bariatric metabolic procedure. And here you can see the number of SMBS in 2019. Here you can see all the studies, all the DS were, included in this code, BPDDS, in 2019. Fortunately, the next 2020 studies here for stain, going to be including 0.2 studies, 1.8, the standard duodenal switch going to be 2%, going to be a very important number. This is the center in 2016 performing a studies procedure, and then in 2024, this year, going to be a little bit more of them. So this is our summary of our preferred approach to studies in very super morbid patient, BMI over 45, and very metabolic patient, and for sure after failed sleep is our ideal procedure, except if the patient is very old, there are some badly performed sleep, or the patient has a severe GERD, where the Roux-en-Y is going to be the ideal approach. Probably, this guy, BMI of 80, is the ideal candidate, 1 or 2 steps. We can decide how to do that, but it's the ideal candidate. So we have to be cautious. We learn about history, the very old patient, the poor control type 2 diabetes, lower BMI, impaired preparative nutritional status, hypertension, other disease, going to be very important problem. And then you are closer to Melbourne, going to be the first week of September. I hope to see many of you over there. Thank you so much for your kind attention.